Welcome to part 2 of the lecture, A Brief History of Global Health. So during the mid-20th century, there became an interest in trying to eradicate certain diseases. Both malaria and smallpox were a focus for the public health community. One of these eradication efforts was successful and one was not. The Global Malaria Eradication Program was launched by the World Health Organization in 1955 and depended on two tools that, at the time, were quite novel: the drug chloroquine for treatment of infected individuals and the chemical DDT for control. Malaria eradication efforts began with a focus on spraying houses with residual insecticides and the prescription of anti-malarial drugs for treatment. There were some initial successes in countries like India and Sri Lanka, which saw dramatic reductions in the number of outbreaks, but unfortunately, these countries saw outbreaks return to previous levels after the eradication efforts stopped. Other nations had minimal progress, such as Indonesia, Haiti, and Afghanistan, and still other countries were excluded from eradication efforts completely. Most of sub-Saharan Africa fell into this category. Ultimately, the eradication campaign failed for four main reasons. First, humans developed resistance to the drug chloroquine, the main treatment for infected individuals. Second, mosquitoes equally developed resistance to the insecticide sprays that were used in homes. Third, we saw massive population movements. This, for example, contributed to the resurgence of malaria in India after the eradication program ended. Drug resistance, with people of different immune status moving from endemic to non-endemic areas, accelerated transmission. Fourth, local populations did not always participate, which made long-term sustainability impossible. In any public health intervention, you must have buy-in from the local population if your efforts are to be successful. In 1977, the original goal of eradication instead turned to one of simply malaria control. In contrast to the malaria eradication effort, smallpox eradication was a resounding success. Smallpox is a highly contagious disease that covers the body with painful blisters. The mortality rate was about 30%, meaning about 30% of all people who contracted smallpox would die. Eradication efforts began in 1967 and a massive worldwide vaccination campaign ensued. The last endemic case of smallpox was reported in 1977, and in May of 1980, smallpox was declared eradicated, meaning that there were no more cases in the entire world. There were several critical differences between the two diseases that made smallpox a great candidate for eradication and malaria more difficult to eradicate. First, smallpox did not have recurrent infectivity, meaning once someone contracted smallpox, it would not come back again. In contrast, a person with malaria can be infected and then the disease can flare up, for lack of a better term, at a later point in time. Second, smallpox had no animal reservoir. Malaria, which is caused by the bite of an infected mosquito, does have an animal reservoir. Third, smallpox had an effective vaccine. Thereby, by vaccinating the population, it could effectively be wiped out given enough of the population. For malaria at the time, there was no vaccine available. Finally, smallpox was easy to prevent and easy to identify and monitor. Malaria is tougher to prevent, and symptoms mirror those of other diseases, making identification more difficult. Essentially, eradication of malaria depended on being able to wipe out the mosquito, which, as you can imagine, is quite difficult to do. In essence, the achievement of smallpox eradication depended not on some possession of a magical weapon, but rather global cooperation. It used classic epidemiologic techniques, including intensive surveillance and disease reporting. The way in which these tools were applied, along with strong cooperation and partnerships, enabled the disease to be eradicated. In the 1970s, the traditional vertical approach that was used in smallpox eradication, essentially top-down approaches that focus narrowly on disease eradication, came under sharp criticism. People became frustrated with the lack of community participation and top-down strategies. People also became skeptical of the Western medicine tertiary care emphasis, essentially specialized care, which was used even in resource-poor areas. There came a growing awareness of the idea that providing medical care was a small and very limited part of improving health. People began to realize that social conditions and non-health services were also vital to improving health. The 1970s saw a reconceptualization of international development. The idea of human development emphasized building from the bottom up through providing basic primary health services and focused on improving socioeconomic status, distributing resources, health system development, and also emphasized basic health services. Another important development in primary health care was the large-scale movement of what were called barefoot doctors in communist China. These providers were a diverse group of village health workers who lived in the communities in which they worked, emphasized rural rather than urban healthcare, and preventive rather than curative services. These barefoot doctors had a profound impact on the country, and huge gains in health status were seen in China. This approach is still used today, particularly in resource-poor areas, and has been overwhelmingly successful. The International Conference on Primary Healthcare took place in 1978 in Alma-Ata, Kazakhstan. The Declaration of Alma-Ata emerged from this conference. The declaration states that health is a fundamental human right, and the attainment of the highest possible level of health is a most important worldwide social goal. This declaration was one of the first that recognized health as a human right. It reiterated the realization that health involves far more than the health sector can accomplish by itself, and it therefore called upon governments, development, and health workers, and the worldwide community to come together to achieve the ambitious goal of health for all by 2020. There were several main themes that emerged from Alma-Ata. First, countries should meet the most basic needs of the entire population, particularly in rural areas, as opposed to concentrating on the needs of urban populations. The second theme that emerged was that community health workers, less skilled clinicians, and traditional healers should be involved in providing care for the population, as opposed to requiring physicians to administer most services. The third theme called for community participation in program design, as opposed to the traditional top-down approach that had been employed. Finally, the fourth theme established that broad interventions that focused on areas outside the traditional health system, such as increasing access to education and promoting gender equality, should be employed instead of relying on the traditional provision of health services and disease eradication. In the aftermath of World War II, there was a push to develop countries that were seen as economically underdeveloped. The emerging development ideology was that increasing development was an economic incentive for the whole world. The idea of a rising tide lifts all boats. It was understood and predicted that development would worsen inequality, but it was believed that ultimately, in the long run, quality of life for all would improve. In this sense, large loans were made to developing countries by financial institutions such as the World Bank and the International Monetary Fund, or IMF. In the late 1970s to mid-1980s, it became apparent that a substantial number of developing countries would not be able to continue to make payments on their debts to commercial banking institutions. In this vein, the idea of structural adjustment programs came about. These programs continued to allow developing countries to take out new loans, but they could only receive the money if they followed certain conditionalities. Some of these conditionalities included the condition that countries reduce public sector spending reduce trade barriers, and reduce state control over the flow of goods and services. In addition, structural adjustment programs encourage privatization, which pushed for the privatization of social service programs. Despite the good intentions of structural adjustment programs, they were a colossal failure. They often caused more harm than good. They failed to bring developing countries out of poverty, but also resulted in harm to the poor. The poorest of the poor were often forced further into poverty due to lower incomes, increasing inequality, and less access to social services. In the year 2000, 189 countries agreed upon the Millennium Development Goals, which were a set of time-bound goals aimed at eradicating extreme poverty and improving health and livelihoods for all worldwide, with a focus on the poor and vulnerable. These goals dominated the development and global health agendas for the next 15 years, as the goals expired in 2015. The MDGs were replaced by the Sustainable Development Goals, which have an expiration of 2030. These goals, like the MDGs, focused on eradicating poverty and improving health and livelihoods for all globally. The SDGs extend the work of the MDGs, yet focus on overall sustainability of progress, as indicated in the goal's name. The SDGs will dominate the global health and development agenda until the year 2030, when the SDGs expire. Today, global health has several important tenets by which practitioners try to abide. Much of this has been learned from past failures and the history that we discussed today. First, we focus on empowering the poor. Empowering the poor by providing them with the resources that they need to improve their own health and lives, rather than doing things for them, is important. Second, we focus on multi-level interventions and do not solely focus on providing medical care. This leads us to the next tenet, which is a focus on the social determinants of health. We realize that we must improve education, gender equality, job security, housing, government policies, and others to improve overall health. Finally, we recognize the need to find solutions that are rooted in local populations. We must have local buy-in and community participation and support if interventions are to be successful. In conclusion, we learned in this lecture that global health and development have had many different eras, and each era had a different focus. Some of these eras were successful, such as the eradication of smallpox, and others were not, such as structural adjustment programs. Today, we apply many of those lessons learned from past successes and failures to move forward in our overall vision of health and well-being for all people worldwide.